Okay, so today's topic is parotid gland. See, this is the parotid region near the ear. This is external ear opening or external acoustic meatus. Okay, and this dotted line, it is representing the parotid gland along with its duct. So the parotid glands, para means around, otic means ear. It lies around the ear. It is the largest salivary gland. What are the salivary glands? Parotid gland, submandibular gland and sublingual gland. Okay, so among these, parotid is the largest. Important for your MCQs. And these are predominantly serous gland. This type is also important. Mainly serous parotid for your histology. Okay, serous glands and that produce watery saliva. Weight of the gland is about 25 gram. Appearance, they are lobulated. This gland is lobulated. Yellow is brown in color. Now, what is the location? The parotid glands are situated in the pyramidal retromandibular fossa or parotid bed. What are the boundaries of this parotid bed? Anteriorly, there is ramus of mandible with medial pterygoid and masseter. Okay, here this is masseter has been shown. And deeper plane, medial pterygoid. And this is ramus of the mandible. These are lying in anterior relation to parotid. Posteriorly, there is mastoid process with sternocleidomastoid and posterior belly of digastric. Here, posterior to this gland, here is the mastoid process, sternocleidomastoid and posterior belly of the digastric. Superiorly, there is external acoustic meatus and temporomandibular joint. External acoustic meatus and here is the temporomandibular joint. Okay. Medially, there is styloid process. Here you can see this is the styloid process. This pointed projection is the styloid process. Now, extent of the parotid gland. Parotid gland is not confined to the parotid bed. It extends anteriorly over the masseter, inferiorly extends in the carotid triangle by crossing the posterior belly of digastric. Posteriorly, it overlaps the sternocleidomastoid muscle. Medially, it surrounds the styloid apparatus and superiorly it surrounds the external acoustic meatus. Okay. Accessory parotid gland. This is asked in your viva. Parotid gland, we have viscera of parotid gland. Today in this section we will see the viscera. Okay, viscera of parotid gland. In during viscera it is asked what is accessory parotid gland. Okay. It is a detached part of parotid gland that lies between the zygomatic arch and the parotid duct and it drains into the main parotid duct. Now capsules or coverings of the parotid gland. So parotid gland has two capsules, true capsule and false capsule or parotid sheath. True capsule is derived from the condensation of fibrous stroma of the gland. False capsule or parotid sheath, it is derived from slitting of investing layer of deep cervical fossa. And the parotid sheath has two lamina, superficial lamina and deep lamina. Superficial lamina is thick, strong, unyielding. See here, this is the two lamina, superficial lamina, deep lamina. These are formed by investing layer of deep cervical fossa. Splitting of this fossa is forming these two lamina. Okay. See the above attachment. This superficial lamina is attached to the zygomatic arch and this deep lamina is attached to the lower margin of external acoustic meatus or tympanic plate and styloid process. Okay. So, false capsule or parotid sheath is derived from splitting of investing layer of deep cervical fossa and the parotid sheath has two lamina. Superficial lamina is thick, strong, unyielding and adherent to the glands and superiorly it is attached to the inferior border of the zygomatic arch. Anteriorly, it blends with the epimysium of the masseter to form the parotidomasseteric fossa, covering both the parotid gland and the masseter muscle. Okay, it is very tough fossa. Okay, very difficult to dissect out. Now, deep lamina is thin, attached to the tympanic plate and stylohyoid process. And stylomandibular ligament is a thickened part of this deep lamina that extends from tip of styloid process to the angle of the mandible. So capsules are true capsule and false capsule. True capsule derived from condensation of the fibrous stroma. False capsule is derived from interesting layer of deep cervical fossa. It has superficial lamina and deep lamina. Superficial lamina thick, strong, unyielding, attachment superiorly to the zygomatic arch, inferiorly, anteriorly forms the parotidomasseteric fossa. And deep lamina is thin, attachments are superiorly to the tympanic plate and styloid process, and derivatives are the stylomandibular ligament. Okay. This stylomandibular ligament, it separates the parotid gland from the submandibular gland. That's why this ligament is important. Now we will discuss the external features of the parotid gland. It resembles an inverted pyramid with apex directed downward. It has an apex, four surfaces, superior surface, opposite to apex, apex is directed downward, so opposite to it, superior surface is the base of the gland. Then superficial surface, anteromedial surface, posteromedial surface, and three borders are the anterior border, posterior border and medial border. Okay. See here, this is lateral view of the gland. Here is a cross section through the parotid gland. See the borders and surfaces. See from this anterior. Here is the anterior border, and this blue one is representing the posterior border. Downward, here is the apex and base is above. For thyroid gland, apex was above, okay, and base was below. But for parotid, it is opposite. Apex is directed downward, okay, base is above. And these are the surfaces opposite to apex. There is superior surface or base of the gland, and this surface you can see from the lateral aspect. Here, this surface is the lateral surface or superficial surface. And in this cross section, you can see this is anterior border. Here is the posterior border, and this part is medial border. Medial border is separating anteromedial surface and posteromedial surface. Okay. An anterior border lying between anteromedial surface and superficial surface. Posterior border is lying between posteromedial surface and superficial surface. Okay. So these are the different borders and surfaces, and this parotid duct is coming out from this middle part of the anterior border. Okay. So these are the presenting parts. For viscera, you have to know all this. Apex is directed downward related to the posterior belly of digastric. Base is the superior surface. Its relations are external acoustic meatus, temporomandibular joint. Then superficial. Then we go to the surfaces. Three surfaces. Superficial surface relations are skin, superficial fossa with great auricular nerve. It is supplying the parotid area. Sensory supply of skin. Then platysma, superficial lamina of the parotid fossa. Next we go to anteromedial surface. Its relations are masseter, ramus of the mandible, medial pterygoid, temporomandibular joint, emerging branches of facial nerve and emerging maxillary artery. Next is posteromedial surface. Its relations are mastoid process, sternocleidomastoid muscle, posterior belly of digastric, styloid apparatus. What is styloid apparatus? It is these are the muscles and nerves related to the styloid process. Muscles, ligaments, and different nerves related to styloid process. and internal carotid artery, internal jugular vein, and last four cranial nerves. Borders are anterior, posterior, and medial. We have seen in previous picture. Now we discuss their part in details. Okay. First is apex. It is directed downward, overlaps the posterior belly of digastric, and structures emerging through the apex are cervical branch of facial nerve, anterior and posterior divisions of the retromandibular vein. Next is superior surface or base. It is concave, forms the upper end of the gland, and it is related to the external acoustic meatus, posterior part of the temporomandibular joint. Structures emerging through the superior surfaces, superficial temporal vessels and auriculotemporal nerve. Then superficial surface, it is the largest. Face is laterally covered by thin superficial fascia with great auricular nerve. Platysma, superficial lamina of the parotid fascia. Preauricular or superficial parotid nodes lie in this superficial fascia. Okay. Now we go to another surface, anteromedial surface. It is deeply grooved by the ramus of the mandible and it is related to these structures. Masseter, posterior border of the ramus of mandible, medial pterygoid, lateral aspect of temporomandibular joint, emerging branches of facial nerve and emerging maxillary artery. Next is posteromedial surface. Okay, it is irregular and it is adapted to the shape of mastoid and styloid processes and their attached muscles. That is sternocleidomastoid, posterior belly of digastric, those. Okay, and it is related to these following structures: mastoid process and sternocleidomastoid, posterior belly of digastric, styloid process and styloid group of muscles. Deep to the styloid apparatus, there is internal carotid artery, internal jugular vein, and last four cranial nerves. 9, 10th, 11th, 12th are related here. Structures entering through the posteromedial surface is facial nerve and external carotid artery. See here, this is also a cross section. See the relations here. This is anterior border, posterior border, medial border, anteromedial surface, posteromedial surface, and lateral surface. See the relations of lateral surface. It is covered by from outside inward skin, superficial fossa with great auricular nerve, then preauricular, then there is deep fossa, okay, formed by the investing layer of the deep investing layer of the deep cervical fossa, forming the parotidomasseteric fossa over this region. And then there is preauricular nodes, lymph nodes, then the superficial surface of the gland is lined. Now see here, within the substance of the gland, three structures are present. From superficial to deep, these are the nerve, facial nerve, then retromandibular vein, and deepmost is the external carotid artery. This is also important. Okay, during dissection of this parotid gland or during surgical different surgery over this gland, you have to protect these structures which are lying embedded within the substance of the gland. Now this anteromedial surface, you can see it is related to this ramus of mandible and its attached muscles on outside masseter, inside medial pterygoid. Okay, and this posteromedial surface here it is related to mastoid process and its two attached muscles, posterior belly of digastric, sternocleidomastoid, and here is the styloid apparatus, styloid process and its attached muscle, and these are the carotid sheath and its structures. The internal carotid artery, internal jugular vein, vagus nerve, 10th, those last four cranial nerves, 9, 10, 11th and 12th. Okay, those four cranial nerves are present here. Okay, so the relations you have understood. Now we go to the anterior border. It separates the superficial surface from the anteromedial surface. And structures emerging from the anterior border from above downward. We'll see in next picture. See the names: temporal branch of facial nerve, zygomatic branch of facial nerve, transverse facial vessels, upper buccal branch of facial nerve, parotid duct, lower buccal branch of facial nerve, and marginal mandibular branch of facial nerve. This is from above downward. Okay, sequence is important. Then posterior border, it separates the superficial surface from the posteromedial surface and it overlaps the sternocleidomastoid muscle. Structures emerging deep to the posterior border is the posterior auricular nerve and posterior auricular branch of facial nerve. Now, medial border or pharyngeal border, it separates the anteromedial surface from the posteromedial surface and it is related to the pharynx. Okay. See here, this is parotid gland, location of the parotid gland near the external acoustic meatus, and these are the structures coming out from the anterior border. See here, this is temporal branch of facial nerve, then transverse facial artery, then zygomatic branch of facial nerve, upper buccal branch of facial nerve, parotid duct, lower buccal branch of facial nerve, marginal mandibular nerve. These are coming out from anterior border. And from the base you can see coming out auriculotemporal nerve and superficial temporal artery and vein, superficial temporal vessels. Posterior to the external acoustic meatus is a posterior auricular nerve. Okay. And here near the apex coming out cervical branch of the facial nerve and the two branches of the retromandibular vein. See here, posterior branch is joining this posterior auricular vein forming external jugular vein. And anterior branch is joining the facial vein to form common facial vein. Common facial vein is going to drain into internal jugular vein. Okay. So these are the structures coming out from different borders of the parotid gland. See, practice a diagram, schematic diagram like this. All those structures I have discussed. Temporal branch of facial, transverse facial artery, zygomatic, upper buccal branch of facial nerve, parotid duct, lower buccal branch of facial nerve, marginal mandibular branch of facial nerve, cervical branch of facial nerve from the apex, and two divisions of retromandibular vein near the apex. Near the base, auriculotemporal nerve and superficial temporal vessels. And posterior to the external acoustic meatus is the posterior auricular nerves and vessels. Okay, understood? So apex, so these are the structures emerging from the parotid gland. Apex, near the apex there is cervical branch of facial nerve, anterior and posterior division of retromandibular vein. From the base, superficial temporal vessels, auriculotemporal nerve. Posteromedial surface, facial nerve, external carotid artery, and anterior border, temporal branch of facial, zygomatic branch of facial nerve, transverse facial vessels, upper buccal branch of facial nerve, parotid duct, lower buccal branch of parotid facial nerve, marginal mandibular branch of facial nerve. And posterior border, posterior auricular nerve, posterior auricular branch of facial nerve. Okay. Now we will discuss the structures within the parotid gland. These are also important. Three main structures. These, if can be identified, they have to identify these structures in the viscera of the gland. Okay. These three structures. Three main structures are present within the parotid gland. From superficial to deep, they are facial nerve and its branches. Here you can see this is facial nerve. Within the substance, it is dividing into multiple branches. Then retromandibular vein. See here, this is retromandibular vein formed by joining of superficial temporal and transverse facial vein. Superficial temporal and maxillary vein, and this is tributary of this vein, transverse facial vein, dividing into anterior and posterior division. And their communication I have discussed. Anterior is joining with facial vein, posterior is joining with posterior auricular vein. Then deepmost is the external carotid artery. Here is the external carotid artery. It is giving its branches. Here is the posterior auricular artery. Here is two divisions, two terminal division, superficial temporal and maxillary. And from the superficial temporal artery coming out this transverse facial artery. Okay. So we'll discuss these three structures in details. Facial nerve emerges from stylomastoid foramen and that runs for about 1 centimeter downward and forward, and it pierces the posteromedial surface of the parotid gland. Intraparotid course of facial nerve. Within the parotid gland, the facial nerve runs forward and divides into temporofacial trunk, which gives temporal and zygomatic branches, and cervicofacial trunk, which gives the buccal, marginal mandibular, and cervical branches. What is pes anserinus? This is asked in your viva. What is pes? The five terminal branches radiate like the goose feet through the anterior border of the parotid gland, and this branching pattern is called the pes anserinus. Okay, understood? Next, we go to the retromandibular vein. The superficial temporal and maxillary veins, they join within the parotid gland to form the retromandibular vein. It runs downward and terminates by dividing into anterior and posterior divisions. Anterior division joins the facial vein to form common facial vein. Posterior division joins the posterior auricular vein to form the external jugular vein. Next is external carotid artery. It enters the parotid glands through the lower part of the posteromedial surface. It runs upward up to the level of neck of the mandible and divides into two terminal branches, superficial temporal and maxillary artery. Superficial temporal artery gives a transverse facial artery in the substance of the parotid gland. Okay. So these are the important structures embedded within the parotid gland. Now we go to the clinical integration. Pates fasciovenous plane. It is a plane that divides the parotid gland into large superficial, here is the large superficial, small deep part connected by a isthmus. Okay, and in between these two parts passes this facial nerve trunk and the retromandibular vein. So this is important plane. So it is a plane. Pates fasciovenous plane is a plane that divides the parotid gland into larger superficial and small deep part of or lobes. Isthmus is a part of glandular tissue. Here is the isthmus present in the Pates fasciovenous plane, and it connects superficial and deep parts. And this plane is traversed by facial nerve and its branches and retromandibular vein. In surgical removal of parotid gland, care should be taken along this plane. Okay, you have to be careful uh, because there is high chance of injury to this nerve and the vein, and if there is injury, there will be heavy bleeding or paralysis of the facial muscles if facial nerve is injured. Okay. So about 80% of salivary gland tumors occur in parotid gland, and mixed parotid tumor or pleomorphic adenoma occur in the superficial part of the parotid gland. Okay. Now we go to the parotid duct. This is asked in your viva. What structures are pierced by this parotid duct? Okay, and where it opens. These are very frequently asked questions during your viva. Where the parotid duct opens and structures pierced by this parotid duct. Also come in your OSCE question if you have to identify the parotid duct during face dissection. Okay. So parotid duct is a thick walled mucomuscular tube. Length is about 5 centimeter. Extent emerges from the anterior border of the parotid gland and opens into the mouth opposite the crown of upper second molar tooth. This is important. It opens in the mouth opposite the crown of upper second molar tooth. What is the course after emerging from parotid gland? See here, this is the parotid duct. After coming out from the gland, it is piercing the buccal pad of fat, then buccopharyngeal fascia, buccinator fascia, then mucus, oral mucosa. Okay. So after emerging from parotid gland, the duct runs forward on the masseter muscle. Here is the masseter muscle between the upper and lower buccal nerves, and then it runs medially along the anterior border of masseter and pierces these structures: buccal pad of fat, buccopharyngeal fascia, buccinator muscle, and oral mucosa. And before piercing the mucosa, the duct runs obliquely forward and opens into the vestibule of the mouth opposite the crown of upper second molar tooth. And this typical course of the duct prevents air entry into the duct during blowing of the mouth, as in trumpet blowers. Okay, this is also important. This oblique course is important to prevent entry of air into the duct. If air entry occurs in the duct, salivary secretion will not occur, because saliva from this parotid duct will come out through this duct only. Okay. So probing of the parotid duct is difficult due to its tortuous course, this oblique course. Palpation of parotid duct, it can be rolled up and down. Sometimes stone formation occurs in this duct. Okay, that stone can be palpated over the masseter. So the parotid duct can be rolled up and down against the tense masseter on clenching the teeth. During clenching of teeth, you can feel the masseter over here. Okay, and the duct lies about 1 finger breadth below the zygomatic arch. Now, parotid scalography, it is a radiological visualization of the parotid duct and its tributaries by injecting radiopaque dye into the parotid duct through its oral opening to see any blockage is present. Okay. Calculi parotid duct may be blocked by a salivary calculi. If calculi is present, dye will not enter the gland. Okay. Now, parotid abscess, it can be drained with Hilton's method by giving a small horizontal incision to avoid injury to the branches of the facial nerve. Okay. Why horizontal incision is given? This is a one explain why question. The branches of the nerve is lying horizontally. Okay. So, if you give horizontal incision, if any nerve is damaged, only single nerve will be damaged. Okay. And if you give vertical incision, all the branches of the nerve will be damaged. So there will be more paralysis if you give vertical incision. That's why it comes as explained why during drainage of parotid abscess we give horizontal incision. Okay, there is less chance of injury to the branches of the facial nerve because the incision line is parallel to the nerve. So parotid duct is a thick-walled mucomuscular tube 5 centimeter in length, opens in the vestibule of mouth opposite the crown of upper second molar teeth. Structures paired by this duct is buccal pad of fat, buccopharyngeal fascia, buccinator muscle, oral mucosa. Clinical aspect: probing, palpation, salivography, and calculi. Okay. Next, we go to the blood supply and lymphatic drainage. Blood supply is supplied by external carotid and superficial temporal arteries. And venous drainage, venous blood from the parotid gland enters the retromandibular vein and external jugular vein. Lymphatic drainage, lymphatics from the parotid drain into the superficial and deep parotid nodes and that finally drain into the deep cervical nodes. Now the nerve supply, it receives these following fibers. Nerve supply is very important. There is a clinical aspect regarding this nerve supply. Fraze syndrome. Okay. So parotid gland is getting these following fibers. Parasympathetic or secretomotor fibers is coming from inferior salivatory nucleus and via the otic ganglion through the auriculotemporal nerve it is supplying the gland. Sympathetic fibers from T1 segment of spinal cord through a plexus around the external carotid artery. And sensory fibers is carried by auriculotemporal nerve and great auricular nerve C2 C3 is the root valve. Great auricular nerve was branched from the cervical plexus. Now, how it is developed? It is ectodermal in origin. Parotid gland develops as an ectodermal furrow from the angle of primitive stomodium. Stomodium is the mouth, primitive mouth. It grows laterally between the mandibular and maxillary processes. These are developing, helps in development of face. Face এর development হয়েছে তোদের class? হয়নি? Okay. So canalization, this furrow gets canalized to form a duct, and this blind end of the duct undergoes multiple branching which later canalizes to form ducts and acini. And due to partial fission of maxillary and mandibular processes, the parotid duct opens into the vestibule of the mouth. Okay. So these are the nerve supply. Parasympathetic supply is secretomotor to the gland. It comes from the otic ganglion via the auriculotemporal nerve. Sympathetic supply, it, it is vasomotor and comes from T1 segment of spinal cord. Now sensory supply is carried by auriculotemporal nerve and great auricular nerve. Okay, so this pathway is also sometimes comes in your theory. So secretomotor pathway for parotid gland, it receives secretomotor or parasympathetic fiber as preganglionic fiber are coming from inferior salivatory nucleus of medulla oblongata. Then it passed through glossopharyngeal nerve, then through the tympanic branch, which enters the middle ear to form tympanic plexus. And then the fibers from this plexus form the lesser petrosal nerve, which enters and runs forward in the middle cranial fossa, and lesser petrosal nerve exits the cranial cavity through foramen ovale and relay in the otic ganglion. And postganglionic fibers start from this otic ganglion, supply the parotid gland through the auriculotemporal nerve. So this is the parasympathetic supply or secretomotor supply to the gland pathway. See here, from the inferior salivatory nucleus of the medulla, the parasympathetic supply is coming, then passing through glossopharyngeal nerve, then in the forming tympanic plexus in the middle ear, then via the lesser petrosal nerve, through the foramen ovale it is coming out from cranial cavity, relaying in otic ganglion and then supplying the gland. And here is the sympathetic supply is coming from T1 segment of spinal cord, passing through the spinal nerve, then relaying in the superior cervical sympathetic ganglion. From here, postganglionic neuron is starting, passing through the plexus around middle meningeal artery, then passing through the otic ganglion, passing via the auriculotemporal nerve and supplying this parotid gland. Okay, so this is course of this sympathetic supply. See here, sympathetic fibers for the parotid gland. Preganglionic fibers begin from lateral horn cells of T1 spinal segment, and these fibers pass through T1 spinal nerve to the thoracic sympathetic chain. Further, the fibers ascend in the cervical sympathetic chain and then relay in the superior cervical sympathetic ganglion. Then postganglionic fibers start in this ganglion. They begin from superior cervical sympathetic ganglia, form a plexus around the carotid arteries. They reach the parotid gland through a plexus around external carotid artery and the plexus around the middle meningeal branch of first part of maxillary artery. This parasympathetic stimulation produces watery secretion, whereas the sympathetic stimulation produces a thick, sticky secretion. Okay, the secretion varies according to the supply. Parasympathetic is causing watery secretion, sympathetic is causing thick, sticky secretion. Okay, these are important for MCQs. And this pathway also important for your solving MCQs. So these are the pathways. See here, this flow chart you remember. For parasympathetic, inferior salivary nucleus, then glossopharyngeal nerve, then tympanic nerve, tympanic plexus, lesser petrosal nerve, otic ganglion, relay. Here relay is occurring. From here postganglionic fibers are starting from otic ganglion. It joins auriculotemporal nerve, reaching the parotid gland. Then sympathetic fibers, preganglionic fibers starting from lateral horn cells of T1 segment, then sympathetic chain, then relay in superior cervical sympathetic ganglion, then postganglionic fibers are starting. They are forming plexus around external carotid middle meningeal artery. Then fibers join the auriculotemporal nerve, reaches parotid gland. Sensory fibers are also passing through the auriculotemporal nerve. They are coming from the skin over the gland, passing through this nerve. Okay. Now, Frey syndrome, important clinical question. Okay. How it also known as auriculotemporal syndrome or Frey-Belanger syndrome and Dupuis syndrome. It is a rare neurological disorder resulting in gustatory sweating. Okay, when we eat food, generally salivary secretion occurs. But in this disease, Frey syndrome, when you eat food, sweating occurs over the parotid region because there is a cross connection among the nerves. How it occurs? Cause is generally damage to the auriculotemporal and great auricular nerves in the parotid gland injuries or surgeries. Anatomical basis of this Frey syndrome. These parasympathetic fibers, you know from the nerve supply, parasympathetic fibers of auriculotemporal nerve, they stimulate the parotid gland to enhance its secretion, and sympathetic fibers of the great auricular nerve, sweat glands, um, and the sympathetic fibers of the great auricular nerve, they supply the sweat glands in the facial skin. After damage to both these nerves, when the regeneration of the nerve occurs, these parasympathetic fibers of auriculotemporal nerve grow and join the sympathetic fibers of great auricular nerve. And this results in sweating rather than salivation during eating. Hence, it is called gustatory sweating or Frey syndrome. Okay. See here, the two nerve fibers are crossing through the auriculotemporal nerve. Parasympathetic fibers are going to parotid gland for salivation. Sympathetic fibers are going to skin, and it was causing sweating and vasodilation. If injury occurs to this nerve, these fibers are crossly connected during regeneration. See, parasympathetic some fibers will be connected to the nerve fiber which is supplying the skin and causing sweating and vasodilatation. And sympathetic fibers will be connected to the parotid gland for salivation. So, when during eating, if the parasympathetic fibers will stimulate, it will cause sweating and vasodilatation instead of salivation. Okay, understood? So, this is very important clinical aspect. Also, will be important during your final years. Next clinical aspect is mumps. It is commonest viral infection of parotid gland and which causes inflammation and swelling of the gland. See here on the both sides parotid gland is inflamed and swelling is present in the parotid region. Very painful due to unyielding nature of the parotid fossa. Generally occurs in children. Inflammation and swelling of the parotid gland, and parotid swelling is very painful due to unyielding nature of the parotid fossa. Okay, it is a tough fossa we have discussed, parotidomesenteric fossa, and irritation of the great auricular nerve occurs due to this swelling and inflammation. Okay, so this is also an important clinical aspect, mumps. Okay, that's all. Any queries? Okay, so for parotid gland, you remember the nerve supply very carefully. For viscera, you have to know the border, surfaces, and the three structures embedded within the parotid gland, and practice a schematic diagram, okay, of what are the structures coming out from different borders of the parotid gland, okay. A histology তে তো পড়েছি salivary gland. It is a serous salivary gland. At different parts MCQ আর OSP এর জন্য তো important ওই Parotid duct is important. It can come as a short note, also asked in your OSPI, Viva like this. Understood? Okay, that's all.
So today's class is basically on CSF. So CSF examination, basically analysis of biochemical parameters, because this is the biochemistry class, and its interpretation. Basically, at the end of the class, you have to diagnose by seeing the report of CSF what type of meningitis it is. That is the basic objective of this class. The commonest indication of CSF examination is meningitis, encephalitis, mainly, and in other cases of the serious tumors or other serious infections. All will lead to almost invariably in all cases meningitis. And the meningitis are classified into three types mainly, regardless of its cause. Actual causative agent, that is, one is viral. There are so many viruses which can cause viral meningitis. Usually meningitis is associated with encephalitis also, because these meninges are covering the brain. That gives them some degree of encephalitis will be there. So meningoencephalitis is the common term. And another is bacteria. So there are many bacteria, out of which one will be infecting the brain, and there are some common bacteria which infect the brain anyway. Third one is tuberculosis. That you will be able to see at the end of this class. First and foremost, you can make a provisional diagnosis by seeing at the sample. If it is not possible, then you can simply look at biochemistry. There are two parameters which I will tell you, that is sugar and protein, that is glucose and protein. Just by looking at these two parameters, you will be able to diagnose without seeing the pathology report. If you have any doubt, or you can see the pathology report also, that is also diagnostic. And if you want to corroborate, then pathology biochemistry both can be corroborated, and you can make a very spot diagnosis. And that at the end of the class you will see. Since you have not been, this CSF cerebrospinal fluid topic has not been covered either in anatomy or in physiology, I'll tell you briefly about the CSF formation, how it circulates. You note some of the salient points which will be useful. This will be of significance throughout the rest of your life, and you will be required to advise for CSF examination. So what is CSF? Last one. Can you tell this is a SGD? You just interact freely. Otherwise, if you don't interact, there is no purpose of having an SGD. This will be just like as good as a lecture class. So this is a small group discussion. You make some mistakes, I am there to rectify, but do speak. What is cerebrospinal fluid? Bolo? It is present in cerebrum, not in spinal cord. Cerebrospinal fluid. So that is basically when there is a fluid which covers the cerebrum. Cerebrum means not only cerebrum, cerebellum is also there. So brain is there and also spinal cord. Cerebrospinal fluid, cerebro means cerebrum, the entire brain, and spinal. So that fluid is, one fluid is there, just like our blood. Blood is circulating through the vessels. Okay, exclusively within the vessels, both arteries and then capillaries and through veins and then the heart. That's a closed system. But from the blood also the tissue fluids are formed, and again the tissue fluids are drained by the venular end through the lymphatic system, again sent back to the circulation. Similarly, CSF is also produced from blood, just like glomerular filtration, urine formation or tissue fluid formation, using ultrafiltrate. So there is a fluid which covers the brain as well as the spinal cord. So that is a cerebrospinal fluid. So where it is present in the brain? Now categorically just note down, it is present in the subarachnoid space. Note down this space. CSF is present in the subarachnoid space. Of course, also in the ventricle system, there are two lateral ventricles, one third ventricle, one fourth ventricle. There are cisterns also, there are sulci, and the spinal canal. Within the spinal cord, there is a spinal canal. That canal is also filled up by cerebrospinal fluid, and on the outside, this is present within the subarachnoid space. This ventricular system means all these four ventricles. And it is produced, where from the CSF is produced? CSF is produced by the choroid plexus. The ependymal lining is there overlying the choroid plexus, from where this CSF is produced. This choroid plexus is just like somewhat glomerulus. From that CSF is produced. Since the two lateral ventricles are bigger in size, the maximum amount of CSF is produced by the lateral ventricles and also by the fourth ventricle and third ventricle and fourth ventricle. So daily secretion is about 750 ml, but the total volume of CSF in an adult is about 150 ml. So that means there is circulation. 750 is produced, 150 is present. That means just minus. So 500 ml is getting recirculated. So the CSF is almost replaced about 5 to 6 hours. The rate of production is about 0.3 to 0.4 ml per minute. That means about 20 ml per hour. CSF flow, as I told you, how does it flow? Over the surface of the brain. I will tell you in briefly in detail how, and down the length of the spinal cord in the subarachnoid space. So this is the thing which you will read, and you might be asked to depict anatomically what is the ventricular system. See, there are two lateral ventricles. You take a coronal section, you will get just like a picture like this. There are two lateral ventricles. This is a third ventricle and this is a fourth ventricle. You see tough capillaries are there. These are called choroid plexus, from where this CSF is produced. So from these two lateral ventricles, there is an opening called foramen Monro. Through foramen Monro, it comes to third ventricle. From third ventricle, it comes to the fourth ventricle via aqueduct of Sylvius. And it goes into the fourth ventricle. From fourth ventricle, there are three openings, two lateral and one medial. I will be telling in detail. From there, it basically circulates in the subarachnoid space, and one part goes down the spinal canal. You put a picture like this. So there are two lateral ventricles. These are connected from where this is coming to the foramen Monro. This is the third ventricle. A third ventricle is here, fourth ventricle is here. That down the line, it is coming out. This is the subarachnoid space. And you will get a picture like this also. So this part will be covered in detail in your anatomy. And if you read it, it will take only half an hour time maximum to understand the entire thing. So that is CSF circulation. This part now you concentrate on this thing. Everything is important. See, there are two lateral ventricles from where, remember, from lateral ventricles there is only one opening, that is called foramen Monro. From this foramen Monro, it comes to the third ventricle. From the third ventricle through the cerebral aqueduct or aqueduct of Sylvius, it comes to fourth ventricle. And in from the fourth ventricle, there are three openings. One is foramen Magendie, that is in the median aperture. Remember, M for median, L for lateral. Lasca, foramen of Lasca is on either side. Foramen Magendie is on the central part. You note down here, passing from the foramen Magendie, it results in a spinal subarachnoid space. And from the foramen of Lasca, it is to the cerebrum. It moves upwards. And from the foramen Magendie, it moves posteriorly and downwards. Then the spinal canal is there. Now then it remains in the subarachnoid space. Since there is a 700 ml of production, 50 production, and 150 ml of present is there, so there is some amount of CSF has to be absorbed. And this absorption takes place through arachnoid villi. Arachnoid granulations are there. This is an avenue for CSF reabsorption. So at the arachnoid villi, remember there is a valve-like mechanism. So it allows CSF to flow from subarachnoid space into the blood, but not vice versa, from blood to CSF. So there must be a valve. So that valve doesn't allow. And this importance is that, clinical significance is that, in the subarachnoid space, CSF comes in contact with the perivascular spaces around the blood vessels. And leaking occurs here. Because if there is inflammation, then only how blood components will come into the CSF. Because this is there is a leak during inflammation. Normal structure will not be there. There will be some amount of inflammation, and that causes the abnormal report in the CSF in disease condition. So this structure I am saying you, if you see the cranium, there is a bony covering, that is, and down the bony covering there is dura mater. If there is any collection between the cranium and the dura mater, that is called extradural space, extradural hemorrhage. If there is anything between dura mater and arachnoid mater, that is called subdural space. And there is this part is arachnoid mater and this is a pia mater. So this green colored material is basically cerebrospinal fluid. So cerebrospinal fluid remains in the subarachnoid space. So as you have learned that it is produced by the lateral ventricles, from third ventricle, fourth ventricle, then from the foramen magnum it comes downwards and posteriorly to cover the spinal subarachnoid space, and through two lateral openings, foramen vasca, it moves upwards to cover the subarachnoid space of the cerebral hemisphere. So this you can see in a very good diagram, a schematic representation I am showing it. Just see this thing. It's a small video, but I will repeat it. So this is the structure. Okay, this is the brain structure. See the CSF. This is the lateral ventricle. You will see how it is moving. What you have, I have told you. This is a representation. এই দেখো, দেখতে পাচ্ছ? See, lateral ventricular production হয়েছে, আসছে, এই যে নিচে নেমে গেল, এই দেখো এখান থেকে ছবিটা দেখো ভালো করে। এই দেখো এদিক দিয়ে বেরিয়েছিল। ঠিক আছে, বুঝতে পেরেছো ব্যাপারটা? দেখা যাচ্ছে? আরেকবার দেখাচ্ছি। কি হলো? ভালো করে দেখো, দেখাও, এটা দেখলে আর ভুলবে না কখনো। ওই যে দিয়ে আলটিমেটলি সুপিরিয়র স্যাজিটাল সাইনাস ভেন দিয়ে ড্রেন হয়ে যাচ্ছে। ওকে, there is another picture I am showing it to you. Now this is a MRI picture. Can you see that there is a fluid covering the brain that you can see? If there would not have been any fluid, you will not get this picture. You get it? This is a functional MRI image. এই ভলিউমটা লেখো। CSF total volume is at a given point of time is about 125 to 150. There will be some variations in the individual. And in the cranial subarachnoid space, that is the maximum amount. This area wise, this area brain is maximally covered, so 100 ml is present there. And spinal subarachnoid space only 25 ml. Remember, CSF has to be collected from the spinal subarachnoid space. Lateral ventricle, as I told you, maximum amount is produced because this hollow size is bigger compared to the third ventricle and fourth ventricle. You can see the volume is about 2 to 3 ml. So these functions you must remember. These 5 points you write down. If CSF would not have been there, then the feeling of the brain would not have been like this. It would not have been so much lighter. You would have a heavy feeling, number one. Number two, it is remaining within the fluid. So it is maintaining some amount of buoyancy. So that is very important. So it is making it light. So there is maintenance of buoyancy, and most important function is protection from injury. If there would not have been a CSF, if there would have been a head injury, it would have hit directly either in this side and on the contralateral side also. But since there is a fluid, the moment there is a head injury, a fluid simply jerks out. There is no injury is not allowed to hit the brain directly. So protection from injury, and this does occur during infancy, so that the volume of the CSF is higher during infancy. It is about 3 to 4 ml, and then it decreases as the child grows, and finally to adult life. You can see, child is supposed to suffer from some amount of head injury. So if the CSF volume is not more, obviously the chance of high head injury will be very high, and it will be causing permanent neurological damage. Second, third is prevention of brain ischemia. So it decreases the intracranial pressure, because see, if there is any block, in the outflow, or if there is any increased formation, obviously CSF will be formed in a much higher amount. So that will exert a pressure. So that will allow ischemia to occur. And if you have, by chance, if any patient develops a high intracranial pressure due to CSF outflow, that happens during meningitis, patients suffer from severe headache. The more the block, the more the headache. Homeostatic regulation, there is cerebral autoregulation. Everywhere in the body there is autoregulation. So there must be a cerebral autoregulation of blood flow, otherwise a huge amount of blood will come, it will not go. So when we are standing up, due to gravity would have come down, so brain would not have got the adequate amount of blood. Every blood would have been pulled out to the leg side. So that doesn't happen. Similarly, when we lie down flat, the blood would have been simply trickled down through gravity towards the brain. Even if we keep the head down and legs up, still the cerebral blood flow level is maintained well. The entire blood doesn't go into the brain. শীর্ষাসন বলে, যে বাংলা যাকে বলে শীর্ষাসন, পা দুটো তুলে দিলাম উপরে, মাথার নিচে রয়ে গেল। And third one, another is removal of waste product. So there is lymphatic system for removing waste product. So this is called a glymphatic system, Glymphatic. The glymphatic system you will see in the anatomy, read in the anatomy. Now coming actual to the biochemistry part. Now you note down here, what is the difference between plasma and CSF? CSF is an ultrafiltrate. An ultrafiltrate basically is a filtration through a semi-permeable membrane by which the colloidal materials are prevented from going out of the circulation. Only the solvent and the small solutes are allowed to pass. So proteins are larger in size. That's why the amount of protein, you see here it is 7 gram. 7 gram means 7,000 milligrams. But here you see it is present in the only milligram concentration, 1,000 times almost less. nearly, if you not 1000 times, see this is 7, this is 45 or 15. See in the, if you see the composition in different areas, so there is some amount of difference in composition, lumbar region, ventricular region, cysternal region, but we usually collect CSF from lumbar region, that's why that is the reference point. So you can see the protein concentration is abruptly low because of the ultrafiltration. Similarly, albumin. Albumin is also a high molecular weight protein. Of course, among the protein, albumin is somewhat lower molecular weight, that is 67 to 80,000, 68,000. So it is present in, here you see this 3.6 gram. But in contrast, it is present in very less amount. That you must remember. Only magnesium and chloride is present in slightly higher concentration in CSF. Clinically, from a biochemical point of view, you see here another important point I have written, uric acid. Uric acid is present here in 2 to 6 milligram. Uric acid structure, if you recall, it is not it is not a soluble material. It's poorly soluble. So urates are formed, they are transported. So because of that solubility problem, the concentration is remarkably low. So by looking at times, what happens, nasal from the, if you read the moment you read this CSF, you will see the cribriform plate of the ethmoid through which nasal mucous membrane comes in contact. And if there is any leak, usually CSF trickles down the nose and a sample is sent where to differentiate whether it is a CSF or whether it is a nasal fluid. So if you know this difference between the composition between the two, then only you will be able to diagnose. Important point to note, last one, but I should have told it in the first one, that C plasma glucose level is higher and CSF glucose level is lower. It is usually 60%. If you see this value, 90 divided by 45 is equal to almost 50%. Okay? And 110 is 80 divided by 110 is almost 70%. So average is 60%. So CSF glucose level is usually 60% of plasma. But remember, it doesn't occur simultaneously. It takes about 3 to 4 hours, even several hours to equilibrate between the CSF plasma, this is the blood plasma and the CSF level. Important point here, I have to ask this question, what is the normal AG ratio in serum? Normal AG ratio in serum is about 1 to 1.5 is to 1. That means albumin is present in higher concentration than globulin, always. Here you see CSF AG ratio is 3 is to 1. You get my point. CSF AG ratio and CSF serum protein, this is the serum protein versus CSF protein. The gradient is about 200 times more, that is 2200 into 3 to 1. So plasma protein concentration is 200 times higher than that of CSF concentration. So these glucose and protein are diagnostically important. You must remember these two values. Other parameters are not done. I repeat, so CSF, glucose and protein is done, not other parameters for routine estimation. Lipid and bilirubin are absent because these are lipophilic materials. So CSF is clear, as good as clear water. Normal CSF. If there would have been bilirubin, then color would have been slightly yellow. If there would have been lipid, then it would have a slightly whitish appearance. But it is not so. This is absolutely absent. So if there is a presence of bilirubin, that means this is abnormal. That you must remember. Where from the CSF will be collected? Because patient has suffered from meningitis or encephalitis, now you have to collect CSF. I have told you so far, about the circulation of CSF. Now, where from CSF will be collected? You. Where from you have seen where the CSF circulation? Now, where from CSF will be collected? This material has to be collected for examination purpose. Now, where from we will collect it? তোমার পাশে সেটা বললো হ্যাঁ হ্যাঁ থার্ড অ্যান্ড ফোর্থ তাই তো আচ্ছা ঠিক আছে কোথেকে পড়লে এটা হ্যাভ ইউ রেড ইট সামহার where he has told it. So from the brain you cannot collect it. Lateral ventricle you have to put the needle in the cranium, not possible. You are likely to injure. The only accessible area is spine. Now, why in L3, L4? Since you have read, let him answer this question. Why from L3 and L4? Why not from T3, T4? That is not T3, T4 thyroid, but Bola? Nerve root is also there. Nerve root is also here. T1, T2, but C1, C2, C1, C3, C3, C4. T3, T4 here, thoracic region. But why specifically at L3, L4? Any idea? No idea. This will be very much clear right now. Next slide. The CSF is collected from the spinal cord, and that he has told correctly L3, L4 vertebra. Why? You see here the spinal cord ends between L1 and L2 lower margin. Okay, so if you puncture above this side, spinal cord is likely to be injured. Now, usually in all cases, there may not be possible that it will end right here. So, one space is usually left. Dura mirror is also there. So, one step down, that between L3 and L4 vertebra, CSF is collected. Now, how will you collect it? I am telling you the procedure. That area has to be made accessible. So, while you go back, you just look at your spine or your friend's spine. You just bend the neck. The most prominent part, you will see that is, you can feel it also. That is the C7 vertebra. You go up, you will be able to count it out. You go down, try to palpate this thing in a little bit thin subjects so that you will be able to see this thing. Once you know that idea, then you, the fatty persons, you have to look at where is the problem. That if you trace the spinous process, then you will be able to know. These you have to palpate, honestly speaking. That spinous process has to be palpated. Now you allow the person to sit down on the side of the bed. Make the spine curve. In the meningitis, there is usually severe pain. Then it is very difficult to bend the patient because spinal nerves are already inflamed. You ask the patient to keep this head end to the flexed end of the knee. So there will be some amount of convexity of the spinal cord, and that will widen the gap. Normally, if you see the spinous processes, these are like this. Now, if you stretch it, suppose this spinous process is like this, if you make a quite curve, if you make a convex, then this area will be increased. So needle can be passed through. That is a basic purpose. Now you put a needle. How will you identify between L3 and L4? How will you identify the L3 and L4? Because in all cases it will not be possible. If you, from here C7 you have to go down, and there is a high possibility. Sacrum, yes. From sacrum can you diagnose? Will you be able to do that? sacrum, all the parts are almost connected. You just try on yourself or your mother or your any sisters are there. You try. You try whether from sacrum. She has also told there is a one approach from the down. See, this is what is required. So you just try from sacrum. No problem. You want. This is how medical research takes place. Somebody has to think something else. Somebody has thought he has invented. You can thought in a different way, and you can make altogether a different protocol. And that is what is desired from a medical practitioner. You add something. From the sacrum, it is usually difficult because if you see the sacrum, almost this vertebra cannot be separated. They are all joined together. And if you look at the spinous process, it will not be that easy. And if you calculate from here, it will be very difficult. From C7, there is C12, and then from L1, L2, L3, L4 vertebrae, isn't it? So there is a high chance that there will be some amount of error. This is not an anatomy class, but still I am telling you. Huh? In kidney position. Kidney position, how will you assess kidney? So that you know anatomically, but in a human being, how will you identify? Suppose here you have to do the LP of her. She is your colleague, she got admitted with a meningitis, and you want to do an LP or vice versa. You have to identify. The ultrasonologist will not be there. Any idea? Just tell me. So, I think you have been told about ilium, this anterior superior spine. Have you ever felt on your body? Have you ever felt? Anterior superior iliac spine, you will be able to feel. Similarly, if you go around the iliac crest, if you go down, you will be able to see the posterior iliac spine, you will be able to feel somehow. Particularly, you can definitely do, all of you can do it, because you are not that fatty. You can simply feel. If you lie down, simply the anterior superior iliac spine will project. So, on the highest point of the iliac crest, put a hand like this. Highest point of the iliac crest, make a perpendicular line, and that will intersect between the L3 and L4. Highest point of the iliac crest, here is the highest point of the iliac crest, make a perpendicular line, and then you try to identify that gap. That gap is basically L3 and L4. Now you put a needle. You select a needle. There are, for a baby, this needle size will not be the same. For a child, for an adult, so there are different needle sizes. Accordingly, you select the needle. Now you put the needle here, you sterilize the area, totally aseptic precaution, just like OT. You put the needle here, there will be some amount of resistance because it is passing through skin. Now you see, this is a ligamentous structure. There is some cartilage structure. So there will be some amount of resistance. Now, suddenly this resistance will give way, because now it is inside the spinal canal. Do you get my point? There will be some amount of resistance, then there will be much more resistance. You will be very gentle while pushing through this thing, because otherwise it will simply, needle will hit the other side. If you cannot maintain the pressure, you have to see that it will give way suddenly, and this needs practice. Without practice, it is not possible. There will be failure, and many big persons also fail to tap a spinal cord, a spinal fluid. So that part you have to have a mastery in that part. Every opportunity you take, sir, give me a chance, let me do it. And the more you fail, the more you will succeed in life. So from here, the moment the needle comes here, usually nothing is required. Fluid will come out from the other end, because it is in the pressure. There is some amount of pressure is there. So there is no negative pressure. So fluid will start trickling down. And while it trickles down, you have to collect it in a vial or in a tube for sending into the analysis. Is this part clear? Now, once this needle is removed, you have to press it hard. The patient, since you have removed some amount of fluid, so there is some amount of drop in the CSF pressure, the patient might suffer from some amount of headache also and uneasiness, for which almost 6 to 7 hours, patient has to be allowed to lie on the bed. He cannot move so easily. Remember, CSF is a very infectious material because bacterial, viral infections are there. So you have to handle it very carefully. Since there is a post-lumbar puncture headache, you have to keep it in mind and you have to deal it accordingly. Or you have to explain there একটু headache হবে আপনার মাথা যন্ত্রণা হবে আপনি কিন্তু বেশি উঠবেন না toileting if required you get it done fast the minimum toileting during that period. So indications now coming to this part. Why lumbar puncture is done? Meningitis is the commonest indication. And at the end, you have to differentiate between these three meningitis. Subarachnoid hemorrhage. Nowadays, this diagnosis is easy because we are having a CT scan. Immediately this can be diagnosed. But during our time, when I was a student, I was an intern, CT was not there in 1956, in 1985 when I passed MBBS. In 86, I did the internship. Actually, from 5th year onwards, from 3rd year, I started assisting operations. 5th year, I have knew all the techniques basically, including LP. So, in internship, I have also examined and I diagnosed the case of subarachnoid hemorrhage by simply CSF examination. And that is what I get that I will show it to you. Brain tumors normally it is not done nowadays because now we are having an advanced imaging system. That is CT, MRI, we can diagnose this case. Other CNS diseases, particularly for Guillain-Barré syndrome, it is required. I have seen 2 cases of Guillain-Barré and that was diagnosed by doing this CSF. So you just remember at least you must be able to know why CSF is required, meningitis, viral, tubercular or and if there is subarachnoid hemorrhage or other brain tumor, CNS infections. Now how these cells and this abnormality comes, this you write down this mechanism, this part. I have told it all earlier that in the subarachnoid space, CSF comes in contact with the perivascular spaces around the blood vessels, entering and leaving the brain, from where cells and protein leak. That is the most important thing. If there is, লেখো না তোমার লিখতে কি অসুবিধা হচ্ছে এই আমার ইরিটেশন লাগা তোমাদের প্রথম দিনে ক্লাসে বলে যে ফোন লিখবে না ফোনে ছবি তুলবে না লেখো না আমি দাঁড়িয়ে রয়েছে সবাই লিখছে পরীক্ষার খাতাতে তোমার ছবিটা আসবে না না লেখো তাহলে খানিকটা মুখস্থ হয়ে যাবে পড়াও হয়ে যাবে যেখানে বুঝতে হচ্ছে না আমাকে জিজ্ঞেস করো simply ask me a question. This is a small group discussion. So in the perivascular spaces, that area undergo inflammation, particularly during meningitis, and cells and protein leak, and these are diagnostic criteria, cells and protein. And if there is an obstruction in the outflow, that is tumor. See, the brain is a very small structure and that structure, that cerebral aqueduct, foramen Monroe, very small opening. See, if there is any tumor or any neoplasm, cyst tumor, anything else, it will compress that particular area. So, there will be some amount of obstruction. So, that will cause an hydrocephalus if it is in a child, but in adult, it causes severe intracranial pressure and other neurological conditions. See, one is albumin, just like blood, it is present in it is the predominant fraction and the ratio is 3:1 as I told you earlier. Globulin levels will be also increased if there is increased permeability and fibrinogen molecular weight is still higher. So, when the permeability is increased very much, then only this fibrinogen level will appear and that is found in tubercular meningitis. And that causes clot formation and coagulum formation. Is this part clear? Everybody has written? Okay. Now, see, once you have put this needle inside, you have to collect in 3 different tubes. One is biochemical, and that vial will go to the glucose and protein only. And cytological, cell count and cell type. Third one is bacteriological because you have to identify the bacteria to select that antibiotic. what proper antibiotic we will give so that this meningitis can be cured. So in these 3 tubes, these samples are collected and it is usually 2 ml in each. So 6 ml of CSF will be collected normally. So that there is out of 150 ml, 6 ml CSF is there, and brain is very sensitive. Some patient might experience also headache. And by mistake also you can put some amount of extra also. That is possible, and why and when you will see right now. So remember, CSF estimation is a priority investigation. The moment you make a CSF, inform the laboratory that one sample of CSF is being sent to you. Please repeat, give the reports as early as possible. Because you have to treat the patient. It is not a routine blood testing. All patients are not that serious, but meningitis cases are definitely very serious patients. They need to be treated very aggressively and as early as possible. So the moment you inform, the laboratory will take the sample on priority and it will analyze and it will send the report. So you just inform the laboratory, sample needs to be centrifuged. So glucose estimation is normally done by the GOD-PD method which you are using. Normal AG ratio, as I have been repeatedly telling, in CSF it is 3:1, in serum protein 200:1. You must remember. The protein estimation is done just by write down the name. There is sulfosalicylic acid. You have done it. You have seen the turbidity. But similarly, turbidity will be there, but this will be a very minute amount because CSF protein is present in very small concentration in contrast to blood or urine. There is another method, that is pyrogalal method, that is just like your blood glucose estimation. So if you sulfosalicylic acid method we have been using in our laboratory and it is quite stable reagent. The results are very reproducible. So we did not go to other methods. See, there is a standard curve. You did not write this thing. You understand? There is standard curve is maintained and OD readings are taken. From the OD readings, what is the protein level, that is measured. And similarly, for the colorimetric estimation, it is just like the distilled water standard test, and that reagent is mixed and it is wet for 10 minutes and reagents are taken. It's nothing more than that. Why you know this thing? Because if the laboratory makes any mistake or if they try to manipulate, then you can go and show me the result. Which method you have used, that is the reason you must know. If you don't know, he will make fool of. They will try to give some amount of explanation. The moment you know that there are 2 methods, known methods, and you show me the result today, what did you get? If he manipulates, he will be caught red-handed, simply there. Because at the end, you have to treat the patient. Only some examination might be fastidious to ask this question, what is Pandit's test? 3 sentences you write, it is a test for globulin in the CSF, marked degree of opalescence is noted, and it is found in multiple sclerosis. These 3 points only, nothing more than that. What is Pandit's test? Pandit's test is for globulin test, not for albumin. It is done in some cases, but those who will answer very well, they might be asked this question. Normally it is not. And this disease is also not that common. Now, concentrate here. Normal appearance of CSF will be just like water, drinking water. It is a clear, transparent and colorless. Appearance in disease. It might be normal or it might be slightly turbid in viral. It might be normal, I repeat, or it might be slightly turbid if the infection is very severe, viral infection, that normal color might change to slight turbidity. Turbid, it is a bacterial. Turbid means there is a pus formation. The more the infection, the more the pus cell, the more the turbidity. It will look like a normal pus cell. I will show you the picture. Cobweb coagulum. Cobweb means a spider web type of thing. That is quite characteristic for tuberculosis. But for that you have to keep the CSF at least for 12 hours standing so that formation will be there. Earlier, there were no diagnostic tests were not that much available, so people were dependent on that thing. Redness or red, if the color is red, CSF, then that means there is a hemorrhage, no doubt about it. If there is clear colorless solution is there, if there is a redness, that means there is some amount of hemorrhage. I don't know where the site is, be it in the ventricle, be it in the brain, be it in the spinal cord, but there is hemorrhage. And xanthochromia is basically Euler's discoloration. This is the reason how I could diagnose that subarachnoid hemorrhage. This indicates old hemorrhage because bilirubin is produced from RBC. So some amount of time has to be given for the hemoglobin to get converted into bilirubin, that hemoglobin into bilirubin. So that is Euler's discoloration. Now, while you are putting a needle, every chance is there might be a vessel. While you are inserting the needle, that vessel might get pricked, isn't it? So that will cause a bloody tap. Or you have accidentally really pricked a vessel. And this is quite possible, this is blind procedure. You don't know whether there is a vessel or not. So mostly it is accidental pricking of blood vessels during LP. So you have to be very careful. So hemorrhagic tap has to be avoided at any cost. Now whether you have done that, you have done this while you are putting, or if there is a hemorrhage, how you differentiate? There might be a hemorrhage already inside the brain. One possibility. Second possibility, there is no hemorrhage inside the brain, but you have made an accidental prick. At the end, you are getting a bloody tap. So here you see where if you make a bloody tap, accidental pricking, so initial blood there will be bleeding. But as you go on collecting the samples, this is the actual color. So that will indicate that there is no hemorrhage inside the brain. If all this color would have been like this, then there is definite hemorrhage. Do you get my point? So if you make a bloody tap, the big problem is that you have to waste almost 6 ml of extra samples. So that will cause 12 ml of CSF you have to draw. So that is likely to cause a severe headache. You are suddenly dropping the blood pressure, CSF pressure down, because if the patient is really having meningitis, he will have a definite headache. On top of which you are, and this is under severe pressure, on which you have put the needle and accidental. So please try to avoid accidental pricking. And if you by chance do it, you know how to remove it. Do not send this sample, hemorrhage sample to the laboratory. They will give blood, and you will be really in trouble. You will not be able to diagnose the case. So there is no hemorrhage at all. Now you can see the color here. See, there is some Euler's discoloration. That is xanthochromia. This is hemorrhage. If you allow to settle it down, blood will centrifuge just like centrifugation. So do not, if you committed a mistake, admit it. That is the best thing. So hemorrhage can be cerebral, it can be subarachnoid, it can be anywhere in the brain. Xanthochromia. Subarachnoid hemorrhage, as I told you, the source of bilirubin is basically heme. So RBC lysis into the CSF that will lead to heme and it will convert them to bilirubin. So wait for at least 12 hours because some amount of time has to be given. So normal color will be like this and xanthochromia will be like this depending on the degree of hemolysis. It can be slightly yellowish, so even it can be deep yellow if there is too much hemorrhage. So by the appearance you will be able to diagnose. There is no need to investigate anything. If there is any bleeding, obviously high protein will be there because there is leakage of protein. Protein has come, this blood cells have come, so high amount of protein will be there. A Froehn syndrome is characterized by 3 things, that is xanthochromia, high protein and marked coagulation. This is one term, albuminous cytological dissociation. Normally, if there is a leak in the CSF, there will be some amount of protein leakage. and cell leakage also. And it will be proportionate. If there is disproportionate rise in the protein compared to the cell, that is called albuminous histological deficiency. And that is quite diagnostic of Guillain-Barré syndrome. So elevated CSF protein পাওয়া যাচ্ছে অনেক বেশি, but relative absence of CSF leukocytosis. CSF পাওয়া যাচ্ছে না, CSF সেলগুলো আসেনি. Normally when there is inflammation, some cells will also come during inflammation. But in this case, that will not be proportionate. So that is called albuminous histological disease. So in the acute phase of Guillain-Barré syndrome, there is elevation of CSF protein without WBC presence. So Guillain-Barré syndrome is basically a viral infection, and here you may not get in the early stage white blood cell. Viral meningitis, as I told you, normal color will be colorless, or it can be slightly turbid because if the infection is severe, more. So this is a normal appearance. It will be just like that. This is a real sample. So findings in viral meningitis কি পাবে দেখো, ভালো করে কালার তারটা দেখে থাকো, clear or colorless or maybe slightly turbid. Protein, it can be normal or slightly increased. Normal protein level is 15 to 45, 40, 45. We have seen 15 to 45 milligram is the normal lumbar puncture protein level. I repeat, normal lumbar puncture protein level is 15 to 45, maybe 40 milligram. Glucose is normal, it is about 60% of the normal blood level. Cell count increased, but it is usually typically within 25 to 500, but if it is severe, then it will be more also. Cell type, mostly lymphocyte. Viral lymphocyte, viral protein is increased, viral sugar is almost normal. Because virus will not be able to take glucose, consume glucose. And number of cells are also less. Bacterial meningitis is turbid, always turbid, always turbid. And you see that degree of turbidity. The more the infection, the more the turbid, and this is a frank pass. Frank pass is there. So bacterial meningitis is always turbid, and the turbidity is dependent, directly proportional to the degree of infection. And what is this? These are basically dead RBCs, dead WBCs. Plus bacteria is present, that is basically causing turbidity. So findings in bacterial meningitis, the appearance will be opalescent or turbid. Protein is increased markedly because there is marked inflammation, so protein will be more than 45 always. It cannot be normal. Glucose will be decreased severely. Why? Because bacteria will consume glucose. That RBC, that polymorphonuclear leukocytes will come to control the infection. So they will come, they will try to consume glucose. So glucose concentration is already very low, and the glucose level will be very low, and it can be zero also. If there is a frank pass, practically you will not get any glucose level. So zero blood, so CSF glucose is acceptable, and I am seen. Usually laboratory doesn't want to give zero. But if you have any diet, if you have seen the pass in the CSF, go to the laboratory, show me the result. The result is usually zero. And cell count, because more polymorphonuclear, because these are basically leukocytes, they will try to control the infection. That is the reason why polymorphonuclear leukocytes are present and these neutrophils are present maximum amount. There is more than 80%. Coagulation may clot on standing. I told you CSF glucose is almost 60%. So if the level is less than 0.6%, it is almost indicative of bacterial meningitis. And as I told you earlier, that it takes about 30 minutes to several hours to calibrate, because if I take blood sample right now from my blood and CSF also, this 60% will not be there. It will indicate 4 hours before what was my blood glucose level. Do you get my point? Suppose right now it is 11 o'clock, 12 o'clock. So what was my blood glucose level at about 8 o'clock or 9 o'clock? That blood glucose, 60% of which will be present in the blood. And what is now, right now my blood glucose level, it will be available. CSF will calibrate almost 3 to 4 hours after that. That you must remember that there is a, the tubercular meningitis, the characteristic feature is coagulation. This is, can you see the network here? This is a network. It's spider-like network. So what is the appearance? CSF will be clear, and this is marked protein increase. There is a severe increase in the inflammation. Cell count will be about usually less than 500. Huh? হ্যাঁ তো আমি জাস্ট চলে এসছি এন্ডে চলে এসছি এবার তোমাদের বলতে হবে তুমি এখন কটা বাজছে ঠিক আছে আমি দেখে দিচ্ছি যে সে যে চলে যেতে পারো আমার কোনো অসুবিধা নেই ক্লাস ইজ অলমোস্ট ওভার দিস ইজ লাস্ট টাইম and now class cell type is basically 500 cell type will be lymphocyte and coagulation will be coagulation. Okay, now coming to the actual exercise, you have to diagnose this case and you will be able to diagnose. Normally CSF 35 maximum 45 করে থাকে এইটা ভাইরাল একটু বাড়বে ব্যাকটেরিয়া বেড়ে যাবে অনেক বেশি টিউবারকুলারে কিন্তু অনেক বেশি বাড়বে গ্লুকোজ লেভেলটা এরকম থাকে এটা নর্মাল থাকতে পারে ব্যাকটেরিয়া অনেক কমে যাবে টিউবারকুলার অনেক কমে যাবে সেল কাউন্টটা দেখে নাও সেল টাইপটা দেখলে এগুলো তো আমরা একই জিনিস বারবার বলছি এইবারে এই চারজনা মিলে বসে বসে বলো এই ডায়াগনোসিস কি করবে সবাই মিলে বলো স্মল গ্রুপ দিস 4%. Now these are the you are really interested. Let them go to the class. Out of class doesn't matter. Now what is the diagnosis? But just by see at the report, I told you this is the basic objective of today's class. Tell something and there will be a small group discussion around 4 students only. Others who are not interested, they have left. I don't mind. Bacterial bolo to, ki bolo? বলো বলো কি ডায়াগনোসিস বলো আর এখন আর ডিসকাশনের মধ্যে না নাও ডায়াগনোসিস বলতে হবে জাস্ট লাইক তোমার ওই যে কেস দিয়েছিল পরীক্ষার সময় তো হোয়াট ইজ দ্য ডায়াগনোসিস প্রফেশনাল ডায়াগনোসিস মেনিঞ্জাইটিস তো বডি মেনিঞ্জাইটিস সবাই প্রথমে কোনটা দেখবে যখন পাংচার করলে তখন কি দেখবে তখনই ডায়াগনোসিস করা যাবে না আর বাকি কিছু দেখার দরকার আছে বলো বাকি কিছু দেখার দরকার আছে আদৌ এটাই আমার ফার্স্ট পয়েন্ট ছিল This is what I am trying to teach you. You will be able to diagnose. পাংচার করে দেখতে পাচ্ছ চোখের সামনে সাদা প্রায় টার্বিড হয়ে গেছে আর কোনো সেকেন্ড কোনো কিছু কথাবার্তা বলারই দরকার নেই কিন্তু ডিগ্রি অফ মার্কেটলি সি দ্য স্টাইলি হোয়াইটিস আছে ডাউট লেগে যেতে পারে একটা ব্যাকটেরিয়াল আছে প্রথমে তারপর তুমি তাকিয়ে দেখো প্রোটিনের লেভেলটা 170 আছে গ্লুকোজটা ড্রপ করেছে 10-এ ঠিক আছে স্লাইডলি বলে যদি বেশি টার্বিড থাকতো তাহলে কিন্তু হোয়াইটিস আছে দেখো অ্যাপিয়ারেন্সটা দেখো হোয়াইটিস লেখা আছে হোয়াইটিস মানে বেসিক্যালি এটা ডেড লিকোসাইট সেই জন্য হোয়াইটিস করা আছে টার্বিডিটি করা কিন্তু নাই ডেলিভারি লেভেল করে নিয়েছে হোয়াইটিস অ্যাপিয়ারেন্সটা সেল কাউন্টার দিকে তাকিয়ে দেখো এগুলো পরে দেখবে প্রথমে ওইখানে দেখি তুমি প্রথমে ফিজিক্যাল অ্যাপিয়ারেন্স দেখি তুমি ডায়াগনোসিস করে দেবে ঠিক আছে দেখো তুমি দেখো সেল কাউন্টটা দেখো টাইপটা দেখো কেন কোন টাইপের সেল বেড়েছে কেন বেড়েছে নিউট্রোফিল বলো কেন লিম্ফোসাইটে বাড়তে পারতো মনে রাখবো সবসময় ব্যাকটেরিয়াল যদি ইনফেকশন হয় তখন নিউট্রোফিল কাউন্টটা বেড়ে যাবে যদি ইমিউনোলজিক্যাল হয় ভাইরাল হয় তখনই লিম্ফোসাইট বাড়ে ব্যাকটেরিয়াল হলে পলিমরফো নিউক্লিওসাইড যখনই কোনো কিছু পেশেন্টের পাবে ফর এনি ডিজিজ you always think this is bacterial contamination. If it is a lymphocyte, think viral or tubercular or something else. It is usually less likely that there is a bacterial infection. So even in the blood report also, if you see the leukocyte count is very high, and out of the leukocyte count on the polymorphonuclear leukocytes, there is neutrophils are count is high, it's usually bacterial. If the leukocyte is, but lymphocyte count is very high, you think it is tuberculosis, or it might be a viral also. You get my point? এইটা বলো। কি করবো বলো, রিপোর্ট তো এরকম এসে গেছে। বলো, তুমি বলো। ভাইরাল, তোমার ভাইরাল ফিভার, ফিভার তোমার ভাইরাল ফিভার তো জন্য তোমার হয় না, ভাইরাল ফিভারের জন্য তো সিএসএফ অ্যানালিসিস করবো না। তুমি বলো। ভাইরাল, ভাইরাল, ভাইরাল ফিভারে কি পয়েন্ট আছে বল দেখি, ভাইরাল ফিভারে কি পয়েন্ট আছে? ভাইরালের ফিভারে কি 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 পয়েন্ট আছে? একটা পয়েন্টও ঠিক থাকতে হবে তো, একটা পয়েন্টে তোমাকে পেতে হবে তো, কোনো একটা সিঙ্গেল পয়েন্ট বার করে তুমি ভাইরালের ফিভারে আছে। লিম্ফোসাইট কোথায় বেড়েছে, আর টোটাল কাউন্টে কত আছে দেখলে? হয়েছে? তুমি তাকে হাইটটা দেখবে, তারপরে যার টোটাল কোলেস্ট্রলটা মনে করো কম আছে, তার এলডিএল এইচডিএল দেখার কিছু লাভ নাই কিছু। টোটাল কোলেস্ট্রল বাড়লে তবে এইচডিএল এলডিএল এর রেশিও দেখবে তুমি। এই মনে করো তোমার আমার হাইট কোনো 5 ফুট 6 ইঞ্চি, যে লোকটা হাইটই 3 ফুট হয়ে আছে, তার হাতের বাম নিয়ে আর করবেটা কি? অলরেডি ডুয়ার্ফ। It's a normal report. Normal patient বলো না, normal report. No, patient normal হয় না। So why I have shown this thing? In many cases, many investigations, you will find a normal report. And patient might argue that why did you do this investigation? The report is, because it is child was a child and the report has come to normal. Now there is a mob, there will be situations. So you have to do some amount of management. So at least there are situations called meningism, means meningitis-like features. But this was not a meningitis, you were in doubt. That's why you have done this test, and this test came out to be normal, and at least you were reassured that at least whatever has happened, report is normal, that means there is no meningitis, it is patient is safe. I thought of something meningitis, but it did not happen. When somebody argues with a normal report, why you have done this test? At least this part I wanted to see that whether this part is normal or not. So during meningism, meningitis-like features occur, but the CSA report will come out to be normal. So that is not meningism I report, but not meningitis. এইটা বলো। বলো। আচ্ছা, কবে উপকরণ করতে গেলে কতক্ষণ সময় লাগবে? কতক্ষণ সময় লাগবে কবে উপকরণ ফর্মেশন করতে গেলে? নর্মালি আমি কি বললাম, সিএসএ যে প্রায়োরিটি স্যাম্পল তুমি সঙ্গে সঙ্গে পাঠাবে, তা তোমাকে একটা তাহলে পাল রেখে দিতে হবে। আমি ইচ্ছে করে এটা দিয়েছি, ইচ্ছে করে দেওয়ার জন্য। নর্মালি আজকালকার দিনে এখন কেউ করে না এটা, ঠিক আছে? কিন্তু তুমি যদি কিউরিয়াস থাকো কোনো জায়গায়, রিপোর্ট পেশেন্টলে একটা তোমার কাছে রেখে দেবে স্যাম্পল, অবজার্ভ করবে। ডাউট আছে তোমার টিউবারকুলোসিসগুলো মনে হচ্ছে, রেখে দেবে, এই অবজার্ভ করবে। সব কিছু পাবে না, তুমি দেখতে পাবে। ফেরি জায়গায় তোমাকে বসে নিজে ব্রেন লাগাতে হবে কাজে। এখন করে কি, এখন টিউবারকুলোসিসের জন্য স্টেন করার জন্য দিয়ে দেবে। যখন ব্যাকটেরিয়া লেগে যাচ্ছে ওখানে তোমার স্টেন করে দেবে, স্টেন করে দিলে ব্যাকটেরিয়াটা দেখতে পাবে, বা ব্যাকটেরিয়া কালচারে বসিয়ে দেবে। এছাড়া আর কি আছে? কবে আমি ইচ্ছা করে দিয়েছিলাম যাতে তোমরা ডায়াগনোসিসটা করতে পারো। কবেটা মনে করো মানে নেই। হ্যাঁ, প্রোটিন অনেক বেশি আছে, দেখেছো? অত হাই অ্যামাউন্ট, এত হাই অ্যামাউন্টে নর্মালি প্রোটিন ব্যাকটেরিয়াল মেনিঞ্জাইটিসে থাকে না। অ্যাবনর্মাল হাই অ্যামাউন্ট অফ প্রোটিন আছে। ওর সঙ্গে দেখো গ্লুকোজ লেভেলটা ম্যাচ করছে না, ভালো করে তাকাও। গ্লুকোজ লেভেলটা ওই অতটা প্রোটিন বেরিয়েছে, কিন্তু সেলটা দেখো সেল কাউন্ট ওইরকম লেভেলে নাই করে মনে দেখিলে স্লাইডলি তার মধ্যে 2100 চলে এসছে, ঠিক আছে, এখানে 550 আছে, কিন্তু প্রোটিনটা ওখানে অত বেশি ছিল না, দেখেছিলে লক্ষ্য করিলে প্রোটিন এখানে কত আছে। টিউবারকুলার মেনিনজাইটিসে ইউজুয়ালি প্রোটিন লেভেল ইজ ভেরি হাই, আর আমি একটা কেস ডায়াগনোসিস করেছিলাম সেটা 5000 পাওয়া গেছে, 5000, that means regardless of anything, it is basically tubercular, and the moment you start anti-tubercular drug, the patient will improve like anything within 7 days time. Okay. And you see here, I told you the lymphocyte count. If you see the count, out of which it is 90% of lymphocyte, if it would have been bacterial, bacterial possible, but then it would have been polymorphonuclear, and the sugar level would not have been like this, and the protein level, compared to the protein level, sugar level would not have been that high. এইটা বলো। নর্মাল, ঠিক। তুমি তো চিন্তা ভাবনা করার একটা সময় দিচ্ছ, একটু সময় ভাবনা দাও, কিছু একটা দিই ওর মধ্যে আছে, আছে ও আছে আছে, এত লুজলি দেখলে হবে না, আপনার কিছু নাই, বাড়ি যান, এত হলবাদি করে ডাক্তারি করা যাবে না, এটা গিভ সাম অ্যামাউন্ট অফ টাইম। হ্যাঁ না, কিছু না কিছু না, ঠিক আছে, চলে যাবে না, তারপর পেশেন্টটা ঘুরে এলো, তারপরে ডেলিভারি এখন হবে না, ও পরে হবে, রাস্তাতে ডেলিভারি হয়ে গেল। এই রিপোর্ট দেখে বলতে পারবো তো, পেশেন্টটা থাকার দরকার নেই তো, মোটামুটি এখন মোটামুটি যে স্টেজে তোমরা এখন আছো, বলতে পারবো তো? হ্যাঁ, বলে দিতে পারবো তো, বলতে পারবো তো, রিপোর্টে পেশেন্টটা দেখার দরকার নেই, রিপোর্টে দেখে বলা যাবে না গো, ওই আগেকার রিপোর্ট যদি 3খানা রিপোর্ট আমি দেখালাম তোমাকে, তাহলে দেখে তুমি বলতে পারবে না এটা কি আছে বলো দেখি, বলে একটু ভাবো, তাহলে দেখো দেবে। তুমি বলো, বলো যা হোক একটা কিছু বলো, দেবো আমি এখনই রেক্টিফাই করে দিচ্ছি, বলো আমি এখন ঠিক করে দেবো। ভাইরাল 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 নর্মাল, নর্মাল ফেভারে কি কি পয়েন্ট আছে বল দেখি, দেখি ক্লিয়ার আছে, ওই একটা দেখি ছেড়ে দিলে ক্লিয়ার আছে, মানে পালস নর্মাল, মানে লোকটা নর্মাল, বাড়ি যাও, আর হার্টে দেখা কিছু দরকার নেই, প্রেশার দেখার খুব বেশি দরকার নেই। আর তুমি বলো ভাইরাল বললো তো, ফেভারে বলো পয়েন্ট। হ্যাঁ, সেল কাউন্টে দেখো, তাকিয়ে ধরেছে, সেল কাউন্টের দিকে তাকিয়েছে, সেল কাউন্টের সেল টাইপটা দেখো, ঠিক আছে, এটা যদি প্যাথোলজি পার্টটা দেখো তাহলে হবে, বায়োকেমিস্ট্রি পার্টটা দেখো আছে, প্রোটিনটা দেখো বেশি স্লাইডলি, আমি তোমাকে বললাম না, শুধু বায়োকেমিস্ট্রি রিপোর্টের দিকে তাকাও, তাহলেই বুঝতে পেরে যাবে, প্রোটিনটা স্লাইডলি দেখো বেশি আছে, মার্জিনটা ছাড়িয়েছে, 45 পর্যন্ত আপার লিমিট ধরেছিলাম, 70 চলে এসছে, আর্লি স্টেজে আছে। ব্লাড গ্লুকোজটা দেখো, অলমোস্ট অনেকের তো ব্লাড গ্লুকোজ কম থাকে, 90 থাকে, হতেই পারে 45 থাকতে পারে, ওই দেখো টোটাল প্রোটিনটা একটু স্লাইডলি বেড়েছে, সেল কাউন্টটা স্লাইডলি বেড়েছে, আর সেটা কিন্তু প্রিডমিনেন্টলি লিম্ফোসাইটে আছে, তো দিস ইজ বেসিক্যালি ভাইরাল। হয়েছে ক্লিয়ার, ব্যাপারটা বোঝা গেল? এবার বলতে পারবো তো, ডায়াগনোসিস করতে পারবো তো, ডায়াগনোসিস করতে পারবো তো, ব্যাস পরে রিপোর্টে দেন, আর কি পেশেন্ট দেখা দেবেন, রিপোর্ট দেন।